Hi, it's Henry Shelford. I'm CEO, co-founder of ADHD UK. This is one of our regular deep dive series, and I'm excited today. We've got someone, one of the authors from Healthwatch England, who've written this extremely important report, recognizing ADHD, how to improve support for people who need it. It's aimed at providing research to feed it to NHS England to change the service that NHS England provides. So without further ado, I introduce Paul. Hello, Paul.
Hi, Henry. How you doing?
Fantastic. And thank you for doing this. Thank you for the report. It's a big deal. It's got a lot of information in there. As a sort of scene setter, do you want to tell people what Healthwatch England is, what this report is, and how you came to be in what you did in it and how you came to be involved?
Yeah, absolutely. So Healthwatch, we're the statutory national champion for anyone, health or social care services. So if you've got any experience at all of visiting your GP or of social care, or of hospital care, you can speak to your local Healthwatch, or you can speak to us directly at Healthwatch England. And our job is to champion those experiences, amplify those voices, and try and get the change that people want to see. That's the context with which we've done this work on ADHD. We were getting a wall of noise really from local Healthwatch teams all over England, who were just flagging lots of the work that ADHD UK does in terms of hugely long waits for ADHD assessment, really poor experiences of support, and of people just really struggling. That was a couple of years ago, which led to us planning this research and getting this report out, which we hope supports the NHS England ADHD task force and just provides some colour to people's experiences and the struggles that they're going through.
And so Healthwatch England, one of the things it does is here's what's happening on the ground and then gets data together, commissions its own research to give policy makers information on which to make decisions and to enable organizations like us to lobby for change. And you've got the local health watches which are doing that locally, that feed into you. That's right?
Yep, that's right. Local Healthwatch are independent of us. They're commissioned by their local authorities, but they do brilliant work in all areas of England to hear the different priorities that local communities might have. And we have a brilliant close relationship with local Healthwatch. They share their data with us. We provide them with support. And it really was a joint effort on the ADHD work in particular. It was because of the concerns raised by people to local Healthwatch and local Healthwatch to us that we wanted to take on this report.
It's adults only. Do you want to talk a bit to why that is?
Yeah, so when we were scoping the work out, there was a number of ways that we could have went with the research. We could have reported on all neurodivergence. We could have looked at adults and younger people. In the end, I guess because of resource and just the time, we wanted to get something out as quickly as possible to raise the concerns that people had. And the quickest way we could do that was to just focus on adults. It's quite a complex landscape looking into children and young people's experiences of ADHD. Because of the different agencies involved, you've got lots of work undertaken by teachers, and the Healthwatch remit is much more surrounded in terms of feeding into the Department of Health and Social Care and NHS England. So that's the reason we took that decision. But it'd be very important for other organisations and potentially Healthwatch in future to look at children's experiences.
Yeah, you've got to start. I think you've got to start somewhere, and adults is obviously a huge number of people, and it's there to look at. Now, once you decided to look into ADHD, you've heard the voices locally. You then opted to do your own research. Could you talk a little bit to the structure of that, how you've done it?
Yeah, so when the ADHD task force was announced, NHS England approached us to help them design their terms of reference. And we did that by involving people with experience of ADHD. So we recruited a number of people with different experiences at different points in the pathway. And yeah, we were really delighted that NHS England wanted to have that lived experience feed in. We did likewise. We spoke to the same group of people who helped us pull together the questions we wanted to ask people across England, and we recruited YouGov to run some field work for us. We asked a number of questions across the impact of ADHD on your life, on employment, on socializing, mental health, the benefits of a diagnosis. We're really keen to hear from people whether a diagnosis helped or not. And we ultimately want to be able to pull together a set of recommendations to change things for the better. So yeah, we had a nationally representative survey. We also ran our own survey to just get some more personal feedback from people. We really wanted to give people the space to talk as openly as possible about the impacts of ADHD and waiting a long time for assessment on their lives. So yeah, there were a couple of different ways we wanted to engage people. But at the core of it, we were really keen that was informed by people living with ADHD and also people delivering care. We tested our questions with lots of clinical experts as well.
And I think one of the things important to talk to, and one of the powers of, and the great thing of having Healthwatch England do this, is that that's the samples they've looked at. They're nationally representative. They're formal samples, and they're things that policymakers take notice of. And that's the critical piece. Like we can do research as a charity, and it's great for pipe feeding, for expressing as it fed into this. That there are issues, and that helps people look at the landscape and what they then need to do, and you gradually prove more and more the issue with clarity that policymakers then make changes on. So I think for YouGov, it's I'm looking at the data now. So there were 2 rounds of surveys, and 1,888 in the first one and 2,579 in the second one. But very importantly, like, it's a managed survey base, which is representative of the population, and that has real significance. You found, and you split the answers. So in terms of the people answering, you obviously ask, do you have ADHD or think you have, and cast those that they're not the sample to look at. And I think that was 86 odd percent. You then had some different categories. Can you talk to that? Because it then divides the data later. So what were the groups of people you found?
Yeah, well, this was something that came directly from people that we spoke to with our deliberative engagement. They recommended that obviously we speak to people with a diagnosis, but lots of the conversations that have happened recently in the media and other places have been around growing awareness. So that there are potentially lots of people who haven't been diagnosed yet who have ADHD, and we were keen to speak to lots of different groups. So we spoke to people who have been diagnosed either by the NHS, right to choose provider, privately, or maybe even outside of the UK. We spoke to people who are on waiting lists, so they've been referred by their GP for an assessment, but they're still waiting. And then a few groups, people who believe they have ADHD, but they couldn't get a referral, people who believe they have ADHD, but haven't yet approached their GP.
Yeah.
For a referral,
and couldn't get a referral when they were rejected by their GP, or
yeah, essentially, yeah. We have a couple of questions that explore that, so there are a number of reasons for that, including potentially just clinical appropriateness. That's not something we're questioning, but we were keen to understand that group at the very least. And then the final group was people who just believe they have ADHD, but for again various reasons don't want a formal diagnosis.
Yeah. And it's important, and it's great that you split it in that way, because they are different groups with different needs. But otherwise, you can often just have people who have an ADHD assessment, and that's as a category was missing. There's a huge amount of people who are waiting, who don't yet know. But that category is then skewed for various reasons. At the moment, we're seeing skews on economics. That lots of the waits are so long in the NHS, lots of people are going privately. That's only available to you if you've got the money to do so. We see issues around different groups, particularly ethnic groups, where we see much lower much lower diagnosis rates. And so having those different categories is important. And there was recent data just showing over 500,000 people on waiting lists for ADHD. So it's a huge cohort of people. And looking at their experiences you've done is really great and very important. In terms of sort of headline numbers for people to know, the number of people diagnosed with ADHD in their sample was about just under 2%. Again, just under 2% had a referral but not been seen. Just under 1% had gone to their GP for a referral but had it declined. And entirely correctly, as you've said, Paul, like some of those that will be clinically appropriate, they were wrong. Like and in some cases not. And I've definitely spoken to people in that latter group. And then you have people, 6% believing they have ADHD but not wanting to get a formal diagnosis, just under 6%, and just under 4% thinking they have ADHD but not coming forward yet. When we spoke, you talked a bit about how you found the ADHD patients quite different from other patient categories, particularly around how much they knew and felt they had to know. Could you talk to that a little?
Yeah, we were just chatting about that. We just found it really interesting. I mean, lots of people we hear from at Healthwatch, particularly those with long-term health conditions, they're experts in their own care. Throughout the years, they understand more and more about their condition and they can advocate for themselves. It was just really striking for ADHD. The people we were speaking to had such a knowledge of the system and the pathways and right to choose, and because they'd had to fight and struggle for assessments or for whatever else over the years. So it was just something that was really striking. It felt like speaking to policy professionals or people engaged with the NHS, which obviously it is. And it was just a really good example of people with long-term conditions being experts in their care. And yeah, you were saying yourself as well, that's something you come across at ADHD UK.
Yeah, we facilitate, we provide that information because people need it. I think the point particularly putting was that I think it's unusual to have those people having such a level of expertise before a diagnosis, and that being quite different. And I think it shows the challenges many are finding around getting a diagnosis. And compared to the ideal, which is where you go to your GP and go, I'm struggling with this, and please, what do you think it is? And that not happening as much. And certainly we obviously talk to a lot of people who've had a decade or more on looking at anxiety and depression and being medicated for that, and it not being recognised that ADHD was potentially the underlying issue. That is not for our discussion. Just added. Right, you found a lot,
but I think it's
yeah, go on.
Sorry, I think it's interesting when you look at some of the further chapters we've got on that, and it's maybe not surprising that people have often had to go away and consult Dr. Google or whatever and try and understand as much as possible, because we have a chapter exploring the referral process and long waits, and there was a reluctance in some cases for GPs to refer simply because of the long waits. So it was about 1 in 4 of that group hadn't been referred because of long waits. About 17% had been recommended to look at private assessments because of long waits. So you've almost got this sort of domino effect of the long waits creating the expertise because people have unmet needs.
You also talked about your data showing that those people who've not come forward, that involved the long waits as well.
Yeah, absolutely. So the group who believe they have an ADHD diagnosis, but have ADHD but don't want a formal diagnosis, they might not want to for a variety of reasons. They've lived with ADHD all their lives. They don't believe that the diagnosis would help, some of them even said. But for others, it was more because of the long waits. They don't want the diagnosis because they don't want to engage with the system. They don't want to experience some of the frustrations of long waits, of battling to get an assessment. So it's not actually that they don't want one. I wonder if we were in a scenario where long waits weren't as long, then those people would come forward as well.
Yeah. So it's people sort of self-removing themselves and not coming forward just because they're like, there's long waits. I can't deal with that. Or, in some cases, self-esteem issues, like going, I don't feel like I'm valuable enough to go and get this medical care, which obviously I think is very sad and wrong. Right, you found a lot of information. A chunk of it you're saving for later, I believe, because there was so much found, and we're looking forward to those reports in the future. And that is all you're going to hear about, that tantalizing future, everyone.
To just a very tiny bit. So yeah, as you said, we had a lot of extra data, and particularly personal insights from people, stories about their lives. So we'll definitely follow up our report with a couple of smaller blogs on specifically the experiences of people with autism and ADHD. That's going to warrant its own piece. And then there have been a lot of challenges in recent years about shared care agreements and medication shortages, and people with a diagnosis struggling to access support. So that's going to be another piece that we'll follow up on in the coming months.
And I think I'm really looking forward to that. They're very important. It'll be great getting that data out so we can lobby for change, like the huge issues around shared care, and around medication. You know, moving within the country at the moment, you have to get reassessed, go to the back of the queue. Your GP and shared care, you can't be sure that you're going to get medication if you move GP, and those are huge problems. And you know, if you're moving for a job and suddenly you find you're not going to be able to get medication, it's a big issue. And so it's fantastic that data will be coming out. You had a number of big findings from this. So talking one-to-one, the one you led with was finding the impact of ADHD to be profound. Could you talk to that?
Yeah, I mean, that's where this work all starts. I think there have been lots of conversations about prevalence and about growing awareness of ADHD. Our report really is just grounded in people's needs. And yeah, the starting point is the absolutely huge impact that ADHD traits and ADHD can have on people's lives. So significantly negative effects on all aspects of life, really, on your health and mental health, on your ability to work, your work performance, whether you can engage with the education system and how you do at university or at school, your ability to manage a household, cleaning and looking after bills and all sorts of things like that. The impact of ADHD on managing relationships as well, and staying in touch with friends, or, you know, some behaviors causing issues in people's relationships. That was specifically for diagnosed people, but we also asked questions of people who haven't had a diagnosis, and there were really similar impacts as well.
One of the things I found really noticeable about that was actually they were all bar one, all slightly worse for the people on the wait list, which is, you know, what you'd guess at as well. But how often do you have to, when you're doing research and talking about a different condition, different health issue, how often do you find yourself having to say and do research saying, like, this is a big deal that impacts their life? Because I feel for ADHD, we're still on the defense, like, people having to justify it too often, and your work's going to be helpful in rebutting that. But how often do you find that's a thing you need to do?
The people's needs are the start of most of our pieces of work, and there's a lot of parallels to draw on this report to wider waits for elective care, because you've got those long waits, often unfortunately without adequate support to people while they're waiting, although that is in broader elective care improving. Yeah, you tend to see it. People are sort of stuck in black holes or just struggling to get any support while they wait. So until they get their assessment or their diagnosis, there's a real struggle. And
yeah, people are coming forward because they're in trouble, right? They're needing support, yeah, exactly. and then they're told, yeah, we agree, we should take this path forward. Yeah, you're struggling, you need help. We'll see you in 2, 3, 4 years. Like, and
yeah,
it's just being
your own work in 10, unfortunately, in some cases. So yeah, that was why we did the work that we've done, to dig into that and understand people's experiences a bit more.
Yeah, and that understanding, ADHD, something we talk to, it impacts every aspect, for almost everyone. It impacts every aspect of their life, from when they get up to when they go to sleep, and it's very significant. And so you then found and confirmed that an ADHD diagnosis changes people's lives.
Yeah, absolutely. Just gives them, in lots of cases, a better understanding of themselves, which is really important to people. You've mentioned self-esteem. That came up a lot. A diagnosis in particular improved self-esteem among 54% of the people we heard from, improved people's ability and gave them the space to manage their mental health and their well-being. And it really helped with concentration at work and studying, so it gave people more confidence in the workplace.
Yeah, and that those sort of questions belying the fact that so many people with ADHD are wanting to succeed in their lives, to do well, to be employed, to stay in employment, to have successful careers. And we see people being able to do that, but that often that missing key is being able to get, that knowledge that you have ADHD, get the support, get adjustments, get medication if you want to, and those things are deprived if you're not picked up in school, but then when you work it out, it's you getting that support, and it being very important. As we've discussed, one of the things, certainly as a charity, we're lobbying for is a proper economic analysis of how important an ADHD diagnosis is, because at the moment, too often we find ourselves arguing with people who only see ADHD assessments as a cost and just ignore the entire benefit side of the equation. And the benefit side is huge, especially as we're 2.5 million people, as confirmed by NHS England recently, and positively impacting our metrics, essentially positively impact every single government metric. And so we're obviously really looking for change. Right, you found a 2-tier service, which we touched on briefly. Do you want to talk about what your results found?
Yeah, we touched on it. We mentioned that some GPs are recommending that people go private because of those long waits. Obviously, that's not an option for lots of people. But in some cases, that's exactly what people are doing. They're going private to try and get the answers that they want. It's again something that we'll touch on more in that shared care piece, particularly the challenges where people get their diagnosis. Maybe it helps them in work, and then they lose access to the medication afterwards, and all their stresses return, all of the challenges return. But again, this is something we've seen across wider elective care as well, that people who can afford to do so, including sometimes people who can't actually afford the private treatment, but their needs have got so complex that they find ways of paying for that. Yeah, we're creating a 2-tier system where access is based on your ability to pay, and that definitely came through in our work.
And certainly waits are not one of the only reasons that people opt to go private. And touching on some of the earlier data points, one of the things we see a lot and is that people they don't want to have an argument with their GP. They don't want to go through that. They're just pretty certain they've got ADHD and want to just find out because they're struggling and they want help and want to know if it's not, or if it is or isn't ADHD. And so wait times being one of the reasons, but just wanting to know and not wanting to argue and have to persuade someone. And we saw in some of the data points of GPs putting people off. And, so if you don't have a good relationship with your GP, you might just feel, I can't go ask for this. You talked about one of your key findings was about hidden weights. Could you talk to that?
Yeah, we've done a separate piece of work on the referral process, and we're actually following up on that. This is for all conditions. We'll be publishing it in July this year. But when you look at hospital waits, the wait time that's recorded starts at the point that the hospital accepts the referral. That's not when people's experience of the condition starts. It starts before they even try and see their GP. So we were trying to reflect the long waits that people have getting a GP appointment, sometimes having multiple GP appointments, sometimes having long conversations, trying to get a referral. And yeah, the different challenges people have to get through before they even get on these very, very long waiting lists. So it's a problem across all areas, but we don't notice it definitely in terms of ADHD waits.
Yeah, and one of the things we're worried about is seeing more of that, where we've got some areas which are removing the GP's um, right to refer, or subtly altering it. So instead, the GP refers to into a triage system, and there being these sort of multiple layers of weight, and that causing huge problems. And particularly one for us to know how many people are waiting and what's happening, but also depriving people of an ADHD assessment when they need one. So yeah,
Yeah, and we mentioned the sort of the clinically appropriate reasons that someone might have for not being referred, and that's absolutely fine, not something that we're questioning at all. But something that came out in our old referrals work and in this one is when you especially look at ADHD traits around attention, around hyperactivity, your GP appointment needs to work for you. The information you get needs to be accessible. You need to be able to understand and feel like you can advocate for yourself. And that was something that came across in the work, that people often didn't find it easy to express themselves. Maybe they didn't feel listened to, or that they couldn't really explain all of their traits properly, or that their traits weren't considered. Appointments being rushed. Appointments not in the format that works for someone. It might, to some people, appointments over the phone are fine, but for others, they're not. So there's all these sorts of things that sit around the actual appointment itself that led people to thinking, actually, I don't feel satisfied with that. I'm not quite sure that I agree that I don't need a referral. So their needs remain, and it's where do those people go next in the system that's really important.
Certainly, we find ourselves often supporting people, like giving advice on how to go and talk to your GP, and often in a terrifying ADHD complex way, we do suggest a list. It's for ADHD is commonly when you're struggling with organization, people are like, have you tried a list? So writing down what you want to say to your GP, and helping you make sure you know to say those things and convey it. But it is difficult. The appointments aren't long, and it's a real challenge. And just making the appointments, it can be a huge challenge. Getting the 8 a.m. or whatever time rush to phone. Certainly, I've had that with my GP. GP's practice, and I sort of said to them, "You're one of the few people who have like the actual medical records that know I have ADHD." It's taken me a couple of weeks just to make this call, and I still mucked up. So it's about 8:30. I was like, "Look, as a reasonable accommodation, could you please just tomorrow? Could you book me in?" And they said no. Which one? I said no. I'm being quite serious. Like, as a reasonable accommodation, like you do have accommodations for making appointments for people who are struggling. Like, I would like to be included in that. So, and they undernard. The next day they did nothing, and the day after they made an appointment. So it worked out, but it was such a challenge. We certainly find, like, as someone with ADHD and talking commonly, like when something's also a problem for other people, but a bigger problem for you because you've got ADHD, you can often find yourself being told just to suck it up because everyone doesn't like it, and that the increased difficulty and need just doesn't get recognized, and it being very challenging. And actually, I do think the GP rush, so being able to access your GP to go and ask, is a significant one.
Yeah, I mentioned at the start, we obviously did the national, the polling, which is really useful to be able to get some numbers and a sense of scale to some of the problems. But we really were keen to do that follow-up survey, which was much more qualitative, much more space for people to give us longer answers and sort of flesh out an idea of how things are for them. And I won't do too much of this, but there just is a really good quote from the report, one of the case studies, who sort of articulates all the stuff we were just talking about. So they say that they went to their GP 6 years ago, believing they had ADHD. They were initially dismissed and told to lay off caffeine and sweets. They went back a second time and then were treated for anxiety. And when they went back a third time, 3 years later, they got referred. But it was only after asking for a right to choose assessment that they were able to be seen a lot quicker. And they were just reflecting on the fact that had they not done that, had they not asked for that right to choose, they might still be waiting. and they were subsequently diagnosed with having ADHD. So just an example really of some of the struggles that people have and some of the expertise they have to be able to get their diagnosis.
Yeah, being told to lay off the caffeine and the sweets, like just, and then being medicated for anxiety, not getting and I think that's it's certainly something we see too often. Is really common. Panorama did a thing on ADHD, which was awful, and we have an entire page on that. People wish to look at that, and our own survey of 2,500 people to show that their main thrust of their points was incorrect, and it's the most complained about panorama of all time. So thank you everyone who participated in that. When they first came out, it was going to have the title ADHD, the false diagnosis, and naive little me was like, oh, maybe they're going to talk to the fact that everyone gets this false diagnosis of anxiety and depression, often for years, sometimes decades, and that it's the false diagnosis and it was really ADHD. Oh, how wrong I was. So hearing these stories, and overuse of caffeine because it's a stimulant is pretty damn common in people struggling with ADHD. And genuinely, when you're seeing someone who's on their 6th Red Bull of the day, the temptation to go, you looked into ADHD is enormous. That's a great quote of that story, and thank you for bringing it up. As part of your research, you found that the support for people waiting for an ADHD assessment was between negligible and very poor in almost all cases, and I think that's something that everyone knows. And when I read that, and a part of me is just like, these are problems we're creating for ourselves by having this. We shouldn't have this crazy wait, and if we are only having to do this because of the problems we're creating for ourselves, and it's just such a just wish it wasn't a thing. Obviously, we've got people waiting. We need them to have support, but the real support they need is to have an assessment in a timely manner and solve the whole problem. You found really interesting information about people and talking to their employer.
Yeah, just a real reluctance for people with diagnosed or suspected ADHD.
You got a number on that reluctance. So what percentage was it?
Only 1 in 5 people we spoke to had done so, had spoke to their employer, and the reasons for not telling employers included all sorts of worries, particularly the stigma around whether that would affect their job or whether they'd feel safe in the job anymore. But
it's a big deal. Like it shows basically, when people are deciding whether or not to tell someone or an organization or anybody anything that they've got ADHD, you're making a decision, which is, I've got a choice. Either I can try and deal with myself and my ADHD, or I can try and deal with myself and my ADHD and their reaction to it. And I need to decide, do I think and their reaction to it is going to be net positive or net negative? And what your data point shows very clearly is that the vast majority, 4/5, think that it will be negative and they don't want to do it. And that's absolute a stain on how we are as a country on ADHD, and that we need to change that. But it's really important that you've gone out and found this data.
And the fact that nearly 2/3 of people we spoke to who did speak to their employer were offered at least one reasonable adjustment, and then 3/4 of that group found the offered reasonable adjustments that they made a difference. So we have some support there which can help people. It's just there's still a long way to go in terms of destigmatizing ADHD, and things I'm sure we've got better than they have been, but when you look at stats like that, it's so important that people can get the help they need to work, they want to work, and reasonable adjustments can help them do that.
Too often we talk to people who have tried to do it without telling and getting adjustments in place, and it doesn't work out, and often too late they then go, look, I have ADHD, I need support, and at which point there's been a lot of damage to their career, their standing in the organization, and it can be very difficult to get back from that. I think the points on your research where you're talking about how percentage of people who were able to get an accommodation in their workplace and that it was impactful, obviously has a skew that they were people who, when they looked at that decision matrix of do I tell people or not, do I think it's going to be net positive or net negative, they were, in their view, it was net negative. So there's a skew for organizations who convey clearly that they are positive around neurodivergence, that they, well, there's a skew for organizations where it looks more positive for someone to talk about ADHD. And yeah, so what that's like in other organizations, I think it needs to change for many. Right. I thought that was important. It's important data on employers, and it's useful that you've done it, and it gives great grounding. You had recommendations.
We did. Yeah, well, one of them, it's obviously a really difficult thing to do, to get the long waits down, and it's not something that can happen overnight. It's something that all services have been grappling with for years, and
Yeah.
we tried to discuss this with particularly the clinical teams who are delivering assessments, and really thank those individuals who spoke to us. And we've come up with this recommendation that we're hopeful can get some momentum about moving ADHD assessments away from where they currently are in hospital teams and more into communities. The reason behind that is that, for starters, the teams delivering the assessments now, we've got quite small teams. They're really overworked, despite working incredibly hard. They're not able to keep up with the rising demand. So we wonder if taking a look at some of the nuts and bolts around a referral and around who can conduct assessments under appropriate supervision might really improve situations and actually free up specialist teams for some very complex cases where ADHD might co-occur with other conditions, or where the individual, the impact on their life has been particularly complex. And
when you say who can conduct an assessment, who are you thinking?
We've recommended that that's something that NICE in particular and NHS England looks at. It could be secondary care teams, just the referral pathway has been set up to the community, so it's closer to people's homes, essentially, with a slightly more generalist look at your life, a much more holistic look at the impact of ADHD on your life and what support you might need, freeing up that demand for more complex secondary care. And obviously, with that, if that change does occur, which we've seen it announced in Australia recently, it would involve all sorts of nuts and bolts around the system that would need to be looked at, including the NICE referral guidance. What could happen in terms of prescribing, and just setting up those pathways in the first place would be complex.
Just so people know what's happened in Australia.
They're looking to move to this community assessment model. And we're hopeful it aligns quite well with the government's proposed shift from moving care out of hospitals and into communities and neighbourhoods. And ADHD could be a really good case study for that, and decrease the long waits and improve people's experiences.
Yeah, and so for people that don't know, so the government has three core shifts within the NHS that they're looking to make. One of them is more care locally than in hospitals, because it's cheaper to provide that. ADHD is a good candidate because we're not using big sophisticated machines, right? It's harder to hoof an MRI machine to the local village than it is to have an ADHD professional be there some of the time. In what's happening in Australia is that, in particular, it's around GPs and GPs being able to provide more support and around ADHD, particularly around medication and annual reviews. That's a huge issue that we've got here. At the moment, GPs aren't able to diagnose. I think one of the big things that we want to make sure is, ADHD has really serious stigma. It has people properly trying to bash it. We've had major politicians essentially talk that an ADHD assessment is a scam, that anyone can get it. Uh, One person who was at that time chairperson of one of the governing party at that time said people are just getting an ADHD diagnosis for their kids to beat the child benefit camp. The idea that you can just get a diagnosis like that, the idea that medical professionals can have the wool pull over their eyes and just give it out like candy, it's just wrong on so many levels. But these are things people believe, and it's what we don't want to have is that in any way ADHD assessment is undermined and that it's not thought to be serious and to have gravitas. If it's seen as too easy, then we're going to start having people questioning it, and we don't want that for individuals themselves, because they need to know it's true so they can make changes in their lives, and we don't want that from the wider public. But so it's definitely an issue. So GPs in this country right now can't diagnose, although I got a terse email from a GP, a singular GP who can diagnose. For those that don't, many medics can take a year out and do other courses and stuff. Like, you can never say all medics, which we made the mistake of saying. So any medical group can't do anything, because there's going to be at least one who's decided some kind of dual path. Anyway, we were corrected. The Royal College of GPs has actually started a pathway to allow GPs to become proficient in ADHD diagnosis. My understanding is that's not started yet, and no one's actually done it yet, but that is coming, and that will make a big, have the potential for big change. But at the moment, GPs are not remunerated around ADHD management. It's not part of their core contract, which is why we're seeing GPs across the country, as a part of their industrial dispute with government, drop, well, either refuse to do shared care, refuse to provide take on new shared care, but we're also seeing people drop shared care and dropping it often to services that don't exist. In terms of it's a very bad thing, and so the look towards formalising it in the community has the potential to be a very big deal. The recommendations you put in place, the NICE guidelines. For those that don't know, so the NHS essentially follows the NICE guidelines. So if the National Institute of Clinical Excellence says this is how you should do it, it actually becomes an obligatory thing for the NHS. And that's why Paul and the team behind this report have put in a recommendation saying NICE needs to look at this to make the changes, because that's the mechanism. Did I cover that right?
That's absolutely, yeah. It's a lot of just the fiddly, boring stuff that happens in the background would have to change inevitably if you're setting up new community pathways. And it might be that we follow that Australian model. It might be that it would actually move to primary care. Some of the clinicians we spoke to about that had maybe tried to set that up, and it was a little bit more complex to set up the pathways given the rules and the contractual stuff in primary care. So that's why we've recommended the move to the community. And you've mentioned as well, we said that'll obviously involve more training and resources to primary and community care teams rather than hospital teams, and that absolutely includes the RCGP stuff on GPs with extended roles. Could become a much more commonplace job title, hopefully.
Yeah, and one of the things we're looking for as a part of that kind of review would be to have formalised policies for people moving geography. You know, at the moment, people having to get reassessed if they move NHS area is it's barking mad. Like, because, you know, I've been assessed 3 times. It's such a waste of resources when you consider how many people are waiting. If you could take out the redo portion, would have a massive impact. And so definitely increasing that. Where do you stand? It's not in the report. I'm veering outside. Where do you stand on virtual? Because community still means going to a clinic, having a clinic, whereas the sort of next step of that is essentially in people's home via virtual assessment. And I know, talking to some providers, they argue very strongly they think that's a real net positive, because you get to see into people's home, and you also don't struggle with an ADHD who a high proportion of which will have arrived late for their appointment, very anxious, with lots of challenges because of that, and then therefore not presenting themselves as their true self because they're mostly overwhelmed by their anxiety of getting there late and rushing and feeling. But also then it's not one-to-one and looking at someone in the eyes and having that experience and all of the granularity of being in the same room with someone. Did you come? What did you? Well, did you have any views on that? Did anything come out on virtual assessments?
Nothing came out when we spoke to people about that. I think ultimately it comes back to choice and what works for individuals. If there was confidence going forward that virtual assessments could, as you said, get that holistic look, see into all aspects of people's lives, which is what's so important to the assessment, and the individual was keen for that, they were given a choice of different appointment methods, and that's what they would choose. If that fits around their life and they can get the information about that appointment, then absolutely that's what we see across all elements of care, is that we want more and more choice for people.
It's also choice for the assessor, right? Like, so an assessor can now be in a very different place, and that can actually increase the supply side of qualified people. If you can have, you're able to have someone who's living somewhere else but has time, it does change what changes how many people can come and support in an area. It's interesting that it didn't come up, just because obviously so many people being seen through Right to Choose, and almost in its entirety Right to Choose is done virtually. I'd suggest that the fact that people weren't talking to it is indicative that people didn't have a problem with it. Because if they did, they would have gone, I was done virtually and I thought it was, I didn't think it was done well enough. So I feel like that lack of it coming up is telling something potentially. I won't push a research person on unknown unknowns. It's very unfair. Going back to the sort of key recommendations, you had moving assessments to the community, you had reviewing the National Institute of Health and Care Excellence, the NICE guidance. I think it's something we're very keen on as well. And we're keen on that for another reason, that we really, really, really want them to put the 18-week promise in. Like, all the writers, people should be seen in 18 weeks. And suddenly we're in the government statistics. And really, that would make a big difference. And we're really included in the push to fulfill the 18-week obligation rather than getting pushed out. At the moment, we're finding we're between a rock and a hard place. You've got big focus on fulfilling the 18-week promise of the NHS, lots of money going in there, and we're not included. You've also got a big focus on increasing mental health within the NHS as a proportion to physical health, and that it needs to go up. But we are specifically carved out of that calculation. And so what you're finding is NHS managers looking at what they can cut, and obviously not what they should. And we're on the chopping block, and that's a huge problem. And any way we could change that is what we're looking for. But so definitely, that's our plea to NICE, amongst other things, obviously. You talked about better support for people waiting for ADHD assessments, and I think particularly seeing the data on how many people are waiting and knowing the impact, it is really important. It's great you're calling out for that. Your fourth one was about collecting and publishing official data on ADHD assessments and waiting times. And in the interim, which has only been a very short time, NHS England has published some data. What's your thinking on that? And does it need to go further? What do you want from now?
Yes, our call is to publish more data so we can understand the pressures, and particularly the demographic data, to just understand who is experiencing the longest waits, where and why. And that's going to require some really robust national official data. The data that was published last week was a first estimate, so it's a good start, but what we want to get towards, and they did announce this in the plan that they released the week before, is that there are goals to get towards this eventually, which will be great. But yeah, we welcome the initial moves, but we want to move to a much more official data set, a bit like what you've already mentioned in terms of the 18-week elective data that's collected. That gets a lot of media attention every month. There are lots of national targets around that. So I think that would really help some transparent official data.
Yeah, it's a big deal. And for people listening, so we haven't had codified data for ADHD. So different integrated care boards, different trusts have logged ADHD differently using different codes, different breakpoints. And that has meant that there's been no national data. There's been no way to collect it. And what's been proposed and is being implemented is the codification. So if someone's been waiting and has not had any contact, that's one category. If someone's waiting and had a first contact, it's another category. And so we have that data, and it was great to see for the first time ever, NHS England said we've worked out how many people have ADHD. It's 2.5 million. Just like it's work we did a few years back, and honestly, like I didn't. Whilst it's great they've done it, I mean, NICE guidelines were in first for ADHD in the year 2000. So to take 25 years to bother to work out how many we are, when it was, I think it's a testament to how badly ADHD has been managed in NHS England up so far. And it's great to see the positive. You've got to celebrate the positive, but also, you know, it can be a bit moany as well. Don't like it. It's been a long time. So look, that is great. I think that particularly that talking around the, you know, we're just getting to the point where we're counted, understanding the split as you've called for on demographic data on, so that's age, gender, ethnicity, sexuality across the board, so we can see which groups are being missed and where more attention needs to be paid. And it is important. And your the last sort of key one amongst many recommendations, but the key ones highlighted was improving employer support for those with ADHD. Did you find anything particularly in there around the support you wanted to see?
The big word we've used is around a move towards proactive offers of reasonable adjustments to staff who would benefit. I think something that's drawn out from the research is just that stigma remains, that reluctance remains from people to come forward and ask for any help that they might need. So we'd be really hopeful of, it need lots of organisations, lots of government agencies working together with business leaders, but to raise awareness of and incentivise a sort of proactive offer of the delivery. And also we'll be feeding into any consultation around the government's decision around access to work and the access to work scheme, around actually expanding that scheme and again improving the access for people, maybe making it a more proactive offer if possible. Because as we said, when people, you know, have an ADHD diagnosis or they're waiting on one, they can just be really reluctant to come forward. So I think that proactive system coming to you would be really helpful to lots of people.
I absolutely agree. And you know, when we've got 4/5 of people not saying they've got ADHD, not getting any support in their workplace because of that, it shows a very significant problem. And proactively going and looking to change that is really important. And your call to do so, I really value. And so thank you for doing that. And it really is. It's thank you for doing all of this. Like doing this research, this analysis, giving us this data is a big deal, and it allows us to argue for change. I know you're arguing for change as well, but without Healthwatch doing this, we don't have the data to argue on that policymakers really listen to. And so this is critical. And I want to say thank you very much for you doing it, for the work you've done, and the change that's going to come from it.
Yeah, thank you, Henry. Cheers.
I think we're out of time, so that's where we've got to say goodbye. Paul, thank you so much for doing this. Yeah, thank you for the work, and I look forward to us doing this again. Hopefully, as you publish more. So, thank you very much, Paul. Thank you.
Cheers.
That's also goodbye for me. So, it's thank you for listening to this. This is part of our deep dive series. We're a small charity. We get no funds from government. Every month is tough on money. Do consider fundraising or donating. We can do literally nothing without that. And thank you for that. Yeah, that's it. Thank you very much. Thanks for listening. Goodbye.